Hi, my name is Jennifer Lau. I am the co-founder and executive director of BEAR, which stands for Biliary Atresia Research and Education. It is my honor to introduce to you Rabbani, who is a transplant hepatology fellow at Stanford and who also has a clinical and research interest in biliary atresia.
Thank you so much, Jen, for that wonderful introduction. Hi, everyone. Thank you so much for being here and for inviting me to talk with you today. I'm sorry I'm not there in person. I know many of you are parents and caregivers or patients living with biliary atresia, and some of you are clinicians who care for these children. My goal today is to walk through the journey of biliary atresia from the diagnosis to the treatment and for some children, transplants. This talk is meant to be honest, but also hopeful. Many children with biliary atresia can live with for years with their native liver. Some will need transplant, though. And the good news is that outcomes today are better than there ever been, and we're hopeful that they will continue to improve. So I think a lot of us in the room probably know what this is, but just so we're all on the same page, biliary atresia is actually conceptually pretty simple. It's a condition where the bile ducts, or the tube that carry bile that's made in the liver, that comes down the liver into the intestines, are there. Those are blocked and scarred away. Bile is important because it helps us digest fat and remove waste from our liver. When that bile can't drain, it can get trapped inside the liver, which causes injury and scarring over time. Now, there's a surgery that can potentially correct this problem called the Kasai portoenterostomy. That surgery connects that liver directly to the intestines to help that bile drain. Some children do really well after the Kasai and may not need a transplant for many years and sometimes even ever. Others will eventually need a transplant. Now, biliary atresia is pretty rare. It affects about 1 in 10,000 to 18,000 babies. It's kind of dispersed a little bit regionally, depending on the area of the world that you live in. Now, it's really important to note that there's nothing that the parents did to cause this. That's something I always want to make sure families hear that clearly. There's nothing they did. This is sadly just the way the bile ducts are formed. Biliary is actually the number one reason for pediatric liver transplants. If you actually take a look at the reasons for any solid organ, so that's that chart on the right there, biliary atresia is actually the number one reason why you're going to get a solid organ transplant. Now, one of the biggest challenges in BA or biliary atresia is timing. The Kasai surgery works really well when it's done early, ideally before 30, 45 days of life. But in many places, babies are diagnosed later than that, often after 60 days of life. So you can see here on this chart, on the y-axis or the up and down axis is transplant free survival. And then on the x-axis or the horizontal axis is the age. You can see that you're more likely to be transplant free the earlier you get this treatment or the Kasai procedure. A lot of work and research is going on right now in biliary atresia, focused on early detection. That's kind of where my clinical and academic and scholarly niche is on early detection. So that's something I want to talk to you guys about today. Now, as I mentioned, and as I just showed you, this disease is usually detected after 60 days of life. That's because these initial signs in the first couple months is simply jaundice or yellowing of the skin or the eyes and pale, kind of chalky stools. Now, a lot of babies are jaundiced when they're first born because of a lot of benign reasons, which can really confuse the picture. And the pale stools are sometimes hard to detect. If you look at the three images on the left of the poops, those are the normal colored ones. And then the six on the right, those are the pale or what we call acolic stools. And I don't know about you, but those are hard to differentiate. So it's really hard to tell what's pale and what's not. And especially when your baby's pooping 7 times a day sometimes, it's really hard to kind of suss that out. And then the jaundice is hard to differentiate because there's a lot of benign reasons for jaundice early in the child's life. There's a group at Texas Children that actually put stories from different families of patients with biliary atresia, and a lot of them have the same story. A lot of them say that they all knew something was going on with their baby, something that they were yellow, they had abnormal poops, and and unfortunately wasn't picked up soon enough. And sadly, multiple studies have reported longer delays in diagnosis in Black and Hispanic infants. Now, one of the most promising tools we have is a simple blood test that measures what's called a direct or conjugated bilirubin. This test identifies babies with what we call cholestasis. All that means is that there's a bile flow problem. That bile that I mentioned gets made in the liver, gets sent down those green highway tracks or the bile ducts into the intestine. If they have a high direct or conjugated bilirubin, that tells me that they have cholestasis, meaning they're having this flow issue. Now, this can be detected as early as the first day of life. And all babies already get their blood tested when they're first born. Usually it's that newborn screen that every single baby in the United States gets at around 24 hours of life. They also get another test called the total bilirubin, and that's looked to see for other causes of jaundice or yellowing and the need for potential bili lights or phototherapy, those blue lights that sometimes you see in the newborn nursery. But with the idea that direct bilirubin is high at birth, direct bilirubin is high for biliary atresia, a group looked back and saw that at birth, all BA babies had high levels at birth when compared to the healthy controls. So that group on the left is patients without biliary atresia. The group on the right are the patients with biliary atresia. You can see they all have high direct or conjugated bilirubin. And for our purposes today, direct or conjugated we're going to use those synonymously. So with that information that direct bilirubin is elevated at birth with biliary atresia, this idea was formed. What if we tested every single baby for direct bilirubin at birth? If high, then we could repeat it at 2 weeks of life. Because with biliary atresia, that direct or conjugated bilirubin continues to climb. And if still high, then the provider should be concerned for BA and make sure they come see us in gastroenterology or hepatology. Well, with that idea, they actually did this. They had amazing results. In an initial pilot study, you can see here of over 11,000 kiddos, they were actually able to capture every single biliary atresia patient. There were two that they captured, and they had a high sensitivity and specificity. Now, that same group wanted to expand and screen over multiple years in multiple different centers. And so they started screening for over 120,000 kiddos. And with that same screen where you test once, if high, test again, if still high, you get them over to GI or hepatology. They found every single biliary atresia patient. The sensitivity is 100% and the specificity over 99%, essentially 100% as well. This is something me and others have been working on, spreading this screening throughout the entire nation from coast to coast at the moment, actually, and a lot of places in between as well. We're trying to get this into the newborn nurseries so that we can pick up every single baby born with biliary atresia in the United States early. But we wanted to make sure that this is really easy for the pediatricians to interpret these direct bilirubin values. Sometimes we get a question of what's high, what's not high, when do I get concerned? So we actually created a specialized calculator called bilyscreen.org to help interpret those direct bilirubin values. You simply input the value. You can see an example here. You put in what the direct bilirubin is, what the age of the patient, if there were any previous values, and the calculator will tell you whether or not to be worried and what next steps to take. The clinicians in the room, the pediatricians in the room will notice this is very similar to another tool called billytool.org that helps interpret that total bilirubin that I talked about earlier, that helps tell us whether or not that this baby needs phototherapy or that Billy lights. This is very similar, but instead of the total bilirubin, this helps interpret the direct bilirubin, direct or conjugated. So if we capture these kids early, we can reduce liver transplants. That's the goal. We know that the earlier we get them to Kasai, the better, meaning less liver transplants. So, and that study of 120,000 kiddos, these were their endpoints, where you can see on the left-hand side there, this is a little plot that shows that you see that line in that orange box. That's the average where they're before screening. Their kids were right above 60 days of life. And then in that blue box, you can see the average, that horizontal line in the bottom of that blue box. After screening, it actually dropped to less than 30 days of life. They were able to get their kids to Kasai. So screening got those patients to Kasai earlier, meaning that better outcomes in the future. What that means is potentially less liver transplants. And new clinical reports came out from the AAP, or the Pediatric Governing Board, if you will, which help identify these kids sooner to improve outcomes. Within it contains a strategy, if you will, which can help primary care providers in the pediatric world to help quickly identify patients with biliary atresia. Now, this article is phenomenal. I highly recommend the clinicians in the audience read it and see what it really has to say. But it really boils down to a simple phrase that we've been trying to spread. This phrase is coined by Dr. Sunny Harpervat, actually at Texas Children, who came up with this. Step one, step two, step three, check eyes, then poop, then first Billy. Now, what does that mean? We've really boiled the entire article down to this one algorithm. At the 2 week visit, so every baby usually gets about a 2 week of life visit with their PCP. That PCP should check the eyes for jaundice because no baby should have those benign causes of jaundice by around 2 weeks of life. Check the poop to see if it's pale. No baby should ever have a pale stool. And check to see if they had a direct bilirubin drawn previously and if that value was high. If any of those three things are true, they should get a direct bilirubin immediately. And if that level is one or more, get them over to GI or hepatology early. Now, with screening, with billyscreen.org, with education to the PCPs, with the new clinical report, and a lot of our outreach programs that we have going on, we're hoping we get these kids to Kasai earlier and ward off transplant, as I've been talking about. But we know that some kids will still need transplant. It is inevitable for some of these kids out there. Their liver doesn't drain very well for a combination of different reasons, which eventually causes, when that bile stays in there, it can be a little toxic to the liver and cause it to become stiff, which can make them not grow well. They can have recurrent infections in the bile ducts. They can have what's called portal hypertension, where the blood backs up to other places. They can get fluid on their belly, or what's called ascites. And they can also get potentially engorged vessels within the GI tract and that are at risk for bleeding. If these things happen, there are transplant centers across the nation that are excellent. The transplant is one of the biggest surgeries someone can undergo. That's why it's a big team with a lot of people. But something I like to recommend that I say to all my patients that the patient's caregivers, they're the biggest part of the team. They're the boss. They make the rules. We're just here to support them. Now, being evaluated for transplant does not mean surgery is happening right away. The evaluation is about making sure transplant is done safe and timed correctly. It's really about when do we think the evaluation process is really about when do we think this patient should go to transplants and making sure we get all the different teams involved that think about these patients. This involves blood tests, different imaging of the abdomen, including that liver and also that spleen, and heart and lung testing, nutritional assessments, meeting with many different teams, including infectious disease colleagues, psychiatric colleagues, social work colleagues, etc. The goal is to understand the child's overall health and determine the best timing of transplants. Now, once that child is listed for transplant, priority is determined using something called the PELD score or the MELD score, depending on the age of the child. This score looks at lab values and growth and complications and things like that. Sometimes the child also receives exception points if there's a situation, if the situation isn't fully captured by the score. Now, waiting times can vary. Sometimes kids wait weeks, sometimes months, sometimes even longer, years occasionally, just really depending on the health of the child and that score that they can receive. During this time, we monitor them very closely and adjust the score or write that exception if needed. Now, there are several types of liver transplants. I won't go into all the technical details of them all, but there's a whole liver from a deceased donor. There's a split liver where one donor liver helps potentially two recipients, or you just get part of a liver. There's also a living donor transplant where a relative or sometimes even a non-relative can donate a portion of their liver. Now, living donor does have some advantages. There's shorter wait times. You can plan it. You can say on this Tuesday, I'm getting surgery. And if you need to reschedule it for one reason, let's say the child is sick with a cold, you can always push that out a few weeks. And they also have pretty good outcomes as well, just as good as deceased liver. If not, maybe some evidence shows that potentially a little bit better. Many children with biliary atresia receive partial liver grafts and do very well. That partial liver will eventually grow in size and act as a full functioning liver. The transplant surgery itself takes anywhere from 6 to 12 hours, really depends on the surgical team and the size of the child and any complications that happen intraoperatively. The surgical team will remove the diseased liver and places the donor liver and connects all these tiny little blood vessels and the bile ducts that I talked about before to that new liver. Um, Once blood flow is restored, the new liver often begins working right away, and sometimes you can now see bile production happen almost immediately, which is pretty fascinating to see. Now, this is a complex surgery, but it is one of those that transplant centers perform, um, quote unquote, routinely. Now, after transplant, we watch closely for complications such as rejection or infection, bleeding. That bile can also leak, and that bile can be caustic a little bit. We also look for blood clots as well. Now, most of these are treatable, especially if caught early. That's why early post-transplant period involves very close monitoring. Now, I want to be really clear. Rejection sounds very scary. If I heard that my child was, their liver was rejecting, that would be very, very scary to me. But it's important to know that rejection is common and often mild, and we're getting really good at treating it. We can detect it early through simple blood tests, and most episodes respond very well to medication adjustments or courses of steroids. Now, rejection doesn't mean transplant failure. It's often something we can actually expect, especially early in its course, and manage pretty appropriately. After transplant, the child will take many medications to prevent rejection and prevent any type of infections. These medications are strongest early on and often decrease over time. Many children end up on fewer medications as the months and years go by. Most children after transplant will go to school, they'll play sports if they want, they'll grow normally, they'll live active, normal lives. Clinic visits are frequent at first, and then they end up spacing out more and more with time. Some recent data demonstrates that significant improvements in post-transplant outcomes over time. In the US, analysis from the Split Society or the Society of Pediatric Liver Transplantation Registry showed that both patient and graft survival improved significantly over the last 20 plus years since 2002, increasing from 90% to 97%. Um, uh, and 81 to 90% for both patient and graft survival, respectively, for primary transplant patients. Now, in summary, we are diagnosing biliary atresia earlier than ever before. We're improving outcomes, and we are supporting families through every step of this journey. Whether your child keeps their native liver or receives a transplant, there is real hope. You're not alone in this journey, and the field is moving forward, and we're moving quickly. There are so many new advances in how we diagnose this disease and how we also treat the disease after it's caught, that I'm very hopeful that we're going to solve this problem. Thank you so much for your time today. It's been an absolute pleasure.
Hello and welcome. We are going to start with Jen Lau from Bear, and we are so happy to have you with us. Dr. Rabbani is there with you in the room. He is definitely working. So we have a lot of physicians that are working today with us because they're either at other conferences or they're on call today. So we appreciate everyone's patience. But since we're here, Jen, tell us a little bit more about Bear and how they help families.
First of all, thank you so much for having myself and for having Dr. Rabbani here. We're here at the Pediatric Liver Transplant Conference, so I apologize if there's any background noises. So I'm the executive director of BEAR, which is Biliary Atresia Research and Education. It was founded in 2022, so we're almost hitting our 5-year mark. Which is great. But personally, really wanted to, and here's Dr. Rabbani. Thank you.
Hi, sorry about that.
We really wanted to create an organization for patients and families who go through the biliary atresia journey. There was not a national organization that was out there. And personally, I am also a parent of a child who was diagnosed with biliary atresia, transplanted, and doing great at 14, but really went through the BA journey myself. So have that lived experience with my child. So we created BEAR to be able to help support patients and families kind of go through those lived experiences. We basically we have kind of two sides to Bear. We have the research and education aspect, which really helps support our physicians, our surgeons, everybody really in the field of GI hepatology and liver transplantation. And then we also have the other side of Bear, which is our community aspect, which is where we have resources for patients and families who may need a little bit of educational awareness in regards to the disease, in regards to what it's like to really kind of navigate biliary atresia prior to transplantation. And then we also have a lot of different types of community programs that we do offer. And one of the biggest community programs that we have been doing recently is visiting a lot of the centers across the country and having what's called a BA Day. And this is where we can give back to the community, give awareness, have some education sessions, and really bring patients and families together to be able to talk about all different types of aspects that kind of hit biliary atresia, whether it's mental health, whether it's nutrition, whether it's school issues, really anything. We have these special roundtables for our patients and families to be able to connect with others and be able to really really talk things out while they're there with us for the BA Day. So that's a little bit about Bear. They can go to our website if they want to learn more, which is bearinc.org. But I really appreciate you having me here and definitely would love to have Teb maybe help answer questions that you may have as well.
Certainly. Jen, thank you. I encourage all the families to go visit Jen and Jordan at Bear. They are amazing. You'll fall in love with them immediately, I promise. And thank you, and Sarah, she's in the chat. She's helping out and sharing those links for us. So if you please go check them out. They're a wonderful resource, and they get to meet in person every once in a while with these Bear on the Road events. I think that is so cool, and you don't see that a lot anymore. So definitely take advantage of that. I'm going to jump into the clinical questions now for Dr. Rabbani. Thank you so much for joining us. And thank you for being such a good steward, and helping us out, even though I know you're incredibly busy.
Oh no, I just want to say thank you so much, Melissa, for putting everything together and to the entire Transplant Families group for today. Thank you so much for putting all this together.
We're so grateful to have you with us, and thank you for that. It means the
Okay.
world to us. I'll start with our first question. It's how quickly can a child with biliary atresia deteriorate while waiting for a liver?
Oh, that's such a good question. So whenever we diagnose a patient with biliary atresia, we always talk to the families about transplants. Not necessarily that your child will go to transplant, especially if we're able to do the Kasai at an early enough time frame. But it's something that we always put in the back of our minds. We want to make sure to mention to the families as well, because it is a potential realistic outcome. Especially if we're talking about a later Kasai or children that are diagnosed too late that we don't do the Kasai because the liver's already scarred over and they need what we call primary transplant, or they can't essentially that's the only surgical option that they have. At that time, we the literature says about 2 years. We usually within a year we'll talk about transplant if we're talking about primary transplants. If they're post if they're post Kasai, um, historically they divided up into thirds. That number has since changed, but we're seeing kids get into their early 4, 5, 6, and then early teen years without requiring a transplant. They can deteriorate quickly. That's why we monitor them really closely with labs, want to make sure we get nutritional assessments too, because these kids are ones that really need some additional help with nutrition. So our dietitian's always actively involved, making sure they're getting appropriate calories, which is usually an additional calories and additional fats, and making sure their vitamins are nicely replenished and those kind of things that sometimes they can have problem with as that bile is slowly starting to regain access into the intestines and starting to break down some of those the food that we eat. So to answer your question, it can be quick. In some cases, especially if it's a later diagnosis, meaning like I'll give you a real world example. We have a 4-month-old right now that was missed BA. Very sad story. That's in our hospital. That's we had to immediately list her onto the for transplant because she's pretty sick. We also have other ones that are that can wait till about 6 months, a year until we have to start talking about more aggressively transplants. But if they are non-Kasai, we will immediately list them for transplant because we know that that is the only option for them.
Wow, that's quite a journey. Thank you for answering that. We have another question. How do living donor liver transplants factor into the biliary atresia journey? Can an adult donate part of their liver to their child?
Oh, yes, that's such a great, important question. So, about 30% of the centers right now offer living donor. So, not all of them, but a good chunk of them do. And it's always an option for a related donor or a non-related donor in some cases. So, you mentioned can an adult donate? That is usually the case. There are certain restrictions on that. First, for age, one, there's a lower cutoff and there's an upper cutoff. And we want to make sure that some of the blood types match, the size, some of the vessels going to the organ are all appropriate because not most all of us have typical anatomy with the normal inflow of vessels going in and outflow, but some of us actually, when we get imaging, we have perfectly normal livers, but sometimes the anatomy is a little bit different, so we don't want to use those offers. But what we they can do is for a living donor, the surgeons will take a piece of that segment of liver, a small piece, and implant it into the child's liver. Both of the most amazing thing, for the adult, they're usually out of the hospital a few days, like 3, 4 days, and they're out of the hospital just on some pain meds. And and their liver will eventually go back to normal size. Same with the child. That liver will also go back to normal size eventually with time over the next 3 to 6 months or so. It will start to grow and expand. We do have some risks involved anytime we do any type of cut down of the liver. So whenever you cut the liver, there can be leaks, either that's like bile coming out there because there's a lot of little bile ducts inside the liver that sometimes can leak out. It's pretty rare, but it can happen. So something that we always want to make sure we look out for.
That's great. Thank you so much. I think we have time for one more question,
Great.
and I will go over this. Do kids with BA have to watch what they eat pre-transplant? Is nutrition important?
Oh, yes. So whenever we go to the Kasai, actually, one of our protocols is we actually usually send them out of the OR with a tube that goes from the nose to the stomach. And we usually increase their calories in their formula. Usually, what we typically do is what's something called basic breast milk or formula is 20 calories per 1 ounce. We actually usually fortify that further to give them additional calories because we know that these babies are working a little bit harder, they're expending a little bit of energy, and they could use all the extra fat and muscle that they could get. So we usually will send them home with an NG tube and just to optimize their nutrition a little bit more. We'll also make sure to, as I mentioned before, check their vitamin levels to make sure all those are appropriate as that bile is starting to start to flow back. Now, once that bile is nicely flowing in the next 3 to 6 months or so, then we'll talk about pulling that tube out. And so the baby can just eat by mouth like anyone else. Now, during that period, the baby's still eating by mouth, but we'll just supplement with the NG tube. But so nutrition is key. It is after the transplant, that is one of the most active things that we can do to make sure that that bile continues to flow, is nutritionally optimize them.
Excellent. We did have a transition question in the chat, but I think we're out of time. So I encourage them to stick around for our future sessions that there's some well-being after transplants. So
Absolutely. And if there are any like pressing questions, do you mind giving out my email address? Happy to answer any additional questions or anything like that. I don't know if you can put it in the chat or I can put it in the chat maybe.
yeah, absolutely.
Yeah, I'll put it in the chat. If there are any parents or anything like that that have any questions, feel free to reach out to me. Happy to answer any additional ones. I'll be a little bit for any actual medical advice, but any general questions, absolutely happy to answer.
Dr. Rabbani, thank you so much. Thank you,
Of course.
Jen. You guys are the best. Look at this power
Absolutely.
team here. We appreciate you so much. I know that you're rushing off to the airport now, so I appreciate your time for us today.
Of
And
course.
we'll pass any additional questions to you after the fact. Thank you.
Sounds good. Thank you.
Take care.
We'll see you soon. Bye.
Bye.